Hello guys, today let's learn about chronic tonsillitis. When duration of infection is more than 12 weeks or you can say 3 months, we can call it as chronic tonsillitis. Coming to etiology, subclinical infection of the tonsil can be one of the cause for chronic tonsillitis, or chronic infection in the teeth or sinuses can be predisposing factors for chronic tonsillitis. Coming to clinical features, here we'll see recurrent attacks of sore throat, cough with throat irritation, bad taste in mouth, muffled speech or you can say thick speech, difficulty in swallowing and drooling of saliva. Tell me in the comment box what are the cardinal features or signs of chronic tonsillitis. Now we'll see about the types of chronic tonsillitis. So first we have chronic follicular tonsillitis, chronic parenchymatous tonsillitis and chronic fibroid tonsillitis. In chronic follicular, you'll see the tonsil will be enlarged but a yellow pus deposition, that may be of calcium deposition or something else. In chronic parenchymatous, the tonsil will be enlarged. In chronic fibroid, it is due to antigen antibody reaction. Here the tonsil will be small due to fibrosis, but on applying pressure there is pus oozing out of the tonsil, and this is called Irwin Moore test, and this is one of the cardinal features of chronic tonsillitis. The second is jugulodigestic lymph node enlargement, but it is non-tender. Keep in mind, non-tender. Okay, so these are the types and clinical features of chronic tonsillitis. Let's know about indications of tonsillectomy. In absolute indication, we have huge tonsils causing oropharyngeal obstruction or sleep apnea or malignancy of tonsil. In relative indications, we have recurrent tonsillitis, second attack of quinsy or peritonsillar abscess, chronic tonsillitis, tonsillitis causing febrile seizures or cardiac disease, IgA nephropathy. Okay, if someone asks what are the non-tonsillar indication of tonsillectomy, you have to tell excision of styloid process and UPP, that is uvulopalatopharyngeal plasty. Sorry. In these cases, if we have to cut down the styloid process because it is enlarged, we have to dissect the tonsils. And one more thing is glossopharyngeal neurectomy. For glossopharyngeal neurectomy, we have to do first tonsillectomy. Okay, so these are the non-tonsillar indications for tonsillectomy. What are the contraindications for tonsillectomy? So same way we have absolute contraindication and relative contraindication. Absolute contraindication is polio epidemic. In case of polio epidemic, tonsillectomy is contraindicated, and submucous cleft palate. In case of submucous cleft palate, to prevent velopharyngeal insufficiency, tonsillectomy is contraindicated. Relative contraindications are acute tonsil infection. In acute cases, we do not go for tonsillectomy, and if age is less than 3 years, it is contraindicated. And recent acute upper respiratory tract infections. So in these cases, it is contraindicated. Let's know some basics about tonsillectomy. So what is the tonsillectomy position? It is known as rose position. Okay, here there is extension at the neck and extension at the atlanto-occipital joint. It's rose position because we want oropharynx to be at lower level than larynx so as to prevent aspiration into the larynx. Okay, so the blood will not go to the throat. So this is about position, tonsillectomy position, that is rose position. What are the instruments used is Boyle tongue depressor, Davis mouth guard, Dreffin's bipod standard, and many more instruments are there. Okay, retractors, anterior retractors, all those things. So what are the techniques for tonsillectomy? We have cold methods, we have hot methods. Okay, in cold method we have microdebrider, harmonic scalpel and cryosurgery. In hot methods we have cautery, laser, radiofrequency ablation and coblation. The direction of tonsillectomy is from upper pole to lower pole, and when you reach to the lower pole it is attached to muscles, so you have to crush it, okay, using Eve's tonsillar snare. So while crushing it will release thromboplastin, and that will cause less bleeding. So this is why we need to crush the lower pole. Okay, do you know about the grading of tonsillitis, chronic tonsillitis? So we have grade 0 means no tonsil, means after tonsillectomy. Okay, grade 1, it is within tonsillar fossa. Grade 2, it is crossing out the anterior pillar but not touching the uvula. Okay, it is crossing out the anterior pillar, does not touching the uvula. Grade 3, it is touching uvula but not touching each other. And grade 4 is touching each other or kissing. Okay, so this is grading of tonsillitis, known as Friedman grading. Let's know about the complications of tonsillectomy. So we have immediate complications and we have delayed complications. In immediate complications, we have hemorrhage. So hemorrhage can be reactionary, means within 2 to 6 hours. Okay. So it may be due to slippage of ligature, or it can be primary within 24 hours. Okay. Or other complications are injuries to tonsillar pillars, uvula and soft palate, injury to teeth, temporomandibular joint, aspiration of blood, facial edema, and surgical emphysema. So these are the immediate complications of tonsillectomy. Coming to delayed complication, we have secondary hemorrhage, that is after 24 hours to 14 days. Then infections, lung complications, scarring of tonsillar pillars and soft palate, tonsillar remnants, and lingual tonsil hypertrophy in response to tonsillectomy. So these are the complications, immediate complication and delayed complication of tonsillectomy. We'll read one more thing. What is Paradise criteria for tonsillectomy? So you have to remember in this sequence only 7 episodes in 1 year, 5 episodes in 2 consecutive years. Keep in mind consecutive, and 3 episodes in 3 years. Okay, so write like this: 7, 5, 3, 1, 2, 3. Okay, so learn this Paradise criteria for tonsillectomy in chronic tonsillitis. So this was about overview about chronic tonsillitis. Thank you so much.